Research Fellow at the Prevent Study and a PhD student at Imperial College London. Welcome, Vaishak, and over to you.
Thank you so much, Pallavi, for the kind introduction. Good evening and good afternoon to all of you for joining from India and UK. Just share my screen. Is the slide visible?
Yes, Vaishak.
Okay. So thank you all for your patient listening, and I really hope you enjoyed the talks till now. Just to give a brief summary, so we've been talking about, we have had some excellent sessions by Professor Tina, Professor Jody, and Sajla regarding the birth companion, e-labor care guide, and intelligent auscultation, respectively. And we've seen how important these might be to prevent the brain injury occurring in neonates. So I'll be talking upon the last of the 4 care bundles, which is neonatal care and normothermia. So unlike the previous care bundles we've been talking, which are mainly for the prevention, the problem when the baby is born and suffers a hypoxic event is that we can no longer go back in time and prevent neonatal encephalopathy, but certainly we can limit the further brain injury. So the key components in the brain-oriented care that we're talking is, one is prompt and adequate basic neonatal resuscitation, appropriate breastfeeding support for mothers and hygienic practices, and this is mainly achieved by empowering mothers and the birth companions, and targeted temperature management of 36.5 degrees Celsius, which is the therapeutic normothermia, and of course optimizing good neonatal intensive care in cases of hypoxic ischemic encephalopathy. Now I'll be going touching upon each component, and the first component being neonatal resuscitation. So approximately 10% of the newborns require some sort of support at birth, and only 1% of these infants need advanced resuscitation in the form of chest compressions or adrenaline or something like that. And the International Liaison Committee on Resuscitation has outlined 3 components for good outcomes, which include guidelines which are based on sound resuscitation science, effective education of the resuscitation providers, and implementation of timely and effective resuscitation. Now, when we look at the evidence for neonatal resuscitation to reduce encephalopathy, we have one major trial done by Waldemar Carlo across a few countries in the low and middle income nations, and which included a massive cohort of 57,643 infants. And they found that even after training the trainers, training the resuscitation providers, there was no reduction in neonatal death at 7 days. And encephalopathy was unfortunately not reported in this particular trial. But however, the stillbirth was reduced. So nevertheless, it is important that all the staffs are trained in neonatal resuscitation, and it's important that not only the pediatrician attending the delivery must be, the birth must be trained, but all the nurses and other supporting staff who are there during the resuscitation have to be trained in at least the basic resuscitation and providing in the basic resuscitation. And the focus must be on the skills and not just certificates. So that's what we've been trying to achieve through Prevent Study by providing basic neonatal resuscitation program across all the sites in Prevent. So we've organized these training programs for mainly focused at the nurses and the staff nurses in the labor room and our intrapartum fetal monitoring nurses, whom we believe are going to be an important part of the team which is there at the resuscitation. Now, the second component is early feeding and hygiene practices. So why is this so important? So when we look at the data from Prevent first phase, we find that 304 infants with encephalopathy or seizures were admitted to the postnatal wards to NICU between 6 hours and 72 hours. So 304 is almost 40% of the recruits. And some of these causes are preventable, such as postnatal collapse. We had 15 cases. We had 75 cases of hypoglycemia, 156 cases of neonatal seizures, which are quite occurring, after 6 hours. So, and a significant number of these seizures might be attributed to a perinatal stroke or infection. So what can we do to reduce the incidence of the babies who are getting encephalopathic quite late and who are not, attributable to a hypoxic event? So we can empower mothers and birth companions for better feeding and hygiene practices. And there are some unique challenges that we face in the low and middle income countries, such as the obsession of certain communities with prelactal feeds and the lack of awareness and importance of early breastfeeding, the importance of colostrum, and the proper formula. If the mother is suffering from reduced breast milk, the lack of support that she gets, and the importance of nipple care, the proper dilution of formula feeds. Most of our mothers and birth companions are unaware of these things, and they are also unaware of the danger signs they need to look for in the baby. And we're trying to reduce this by empowering mothers and birth companions, by training them, creating awareness, and hopefully we know if it works by the reduction of audit outcomes such as seizures, encephalopathy, and postnatal collapse, 6 to 72 hours of birth in the coming phase of the study. So these are the samples of the posters that we are using in the postnatal wards. So we've designed these posters in English as well as the local languages, Malayalam and Kannada. Now, the third component is avoidance of hypothermia. So we have strong evidence from high-income country cooling trials that the odds of death and disability increases almost fourfold for each 1 degree Celsius rise in temperature. And the incidence of hyperthermia seems to be higher in the high-income settings, maybe because they have more warmers, more warmers installed, and each baby is nursed in a warmer. So the incidence of hypothermia in the NICHD trial was 38%, CoolCap trial was 31%, and in TOBI trial was 14%. Whereas in Helix trial, our group took very good care to make sure that the hyperthermia was kept to a minimum, and hence the incidence was only 5%. All this was continuous monitoring, nearly hourly or continuous monitoring, whereas in PREVENT study, we only do 6-hourly monitoring as per now. And even then, with the 6-hourly monitoring, we found a significantly high incidence of hyperthermia, ranging from 7 to 10% across all sites. So is hyperthermia occurring due to the natural response in HIE? No, hyperthermia is almost always iatrogenic, unless the baby is having some sepsis or fever. It's almost always iatrogenic, which we are creating because of the warmer. So this was a study which was done in sub-Saharan African settings by Nicola Robertson, Christabel and team. So they found that the natural response to brain injury was hypothermia, with a nadir occurring at around 15 hours, where the baby is passively, the baby undergoes passive cooling. And this was published in the Journal of Physiology. So it is, except for the cases of sepsis with fever, we can be sure that the hyperthermia is occurring due to the warmers. So what can we do to avoid hyperthermia? Never leave the infant unattended in the manual mode. And always make sure that the skin probe is secured. The baby is on the servo controlled mode, and most often the probe pops out of the baby's skin, and that's when the radiant bomber starts overheating. And the periodic checks should be made to make sure that the skin probe is intact, and at least a chart maintaining a 2-hourly axillary temperature should be done for all HIE babies. And the last component is optimizing neonatal intensive care. So why we are talking more about this is because the mild encephalopathy cases mortality in the UK is around 0.5%. It's less than 1%. But the overall mortality rate of mild HIE in PREVENT is 13%. So since we are using a structured neuroexamination, we are quite sure that we are indeed picking up the mild HIE in the initial neuroexam. But the mortality in mild HIE is much more than expected. So that kind of underlines that we have scope for improvement in the neonatal intensive care with particular respect to the hypothermia. So if you look at the mild HIE mortality without hyperthermia in PREVENT study, it is 11%, and mild HIE with hyperthermia, 26 cases, the mortality is 23%, which is 50 times higher than in GK. So hyperthermia is a big killer, and we should certainly look at steps to eliminate it in the coming year and forwards. Now, there are also comorbidities in mild HIE. When we looked at the data, we saw that almost 37% of the cases had meconic aspiration syndrome, and persistent pulmonary hypertension was also there in almost 30% of the cases who died, and 7.5% of the babies had bloodstream sepsis. So deaths due to respiratory issues and hypothermia are indeed preventable, and we should be looking to improve the care in these in the neonatal intensive care. So that are all about the 4 components. Now, how do we know if a care bundle works? The PREVENT study outcome measures. So the main outcome measures of PREVENT study are 1, moderate or severe neonatal encephalopathy, neonatal seizures, death within 72 hours of birth, brain injury on advanced magnetic resonance imaging, and neurodevelopmental outcome at 18 months. And the primary outcome of the study is epilepsy by 18 months of age. Now, to accurately classify moderate and severe encephalopathy, it is mandatory that we use a structured neuroexamination. So this is the modified SARNAT and SARNAT score developed by the NICHD group, and which consists of 6 components. And this is the neuroexam is highly subjective, and unless you use a structured neuroexam, it is highly probable that you are going to misclassify a lot of mild cases to moderate or severe. So we do a periodic training of all the residents in the NICU by all the clinical research fellows, and we make sure everybody is confident in the accurate classification of encephalopathy. And the next thing which we are doing in PREVENT is accurate classification of neonatal seizures. So there is a strong evidence that just by clinical judgment, it is very hard to arrive upon a diagnosis of neonatal seizure with certainty. So that is why the International League Against Epilepsy came up with this classification, which I mean, the take-home message is that EEG is the gold standard in diagnosing a seizure, and then if you have an EEG confirmed seizure, that is the gold standard, and it classifies as level 1, whereas the type of seizure where you can be most sure clinically are the focal clonic or the focal tonic seizures, so that will come in level 2, and all the other possible seizure-like events are classified as level 3. And even if a movement looks like a seizure, but we don't have an EEG correlate, that is deemed as not a seizure, so that will be classified as level 4. And I mean level 5, and level 4 is just reported clinical events that do not meet case definition. So level 4 and level 5 classifies as not seizure. So we're quite sure about the type of seizure we are capturing in because of the EEG monitoring that we have for all the infants. And this is how we do the EEG monitoring in our NICU. So you can see the acquisition, and of course we all have remote access, and a real-time EEG consultation can be done with Dr. Ronit Bressler, who is at Great Ormond Street Hospital, who is a clinical neurophysiologist. So all the doubtful cases we do escalate to Dr. Ronit and get expert opinion regarding the diagnosis and treatment. And so the next step is magnetic resonance biomarkers. So we do conventional imaging, MR spectroscopy, and diffusion weighted sequences. And there is strong evidence that MR spectroscopic biomarkers are having very good accuracy to predict the long-term neurodevelopmental outcome. And last but not least, at 18 to 22 months, we do the long-term neurodevelopmental assessment, which is the Bailey 4 assessments. So our first baby is going to be due in January, later this month. So that's our first Bailey assessment is going to be nearing. So those are all the outcome measure, how we quantify the outcomes of the study. And I'd just like to summarize all the take-home messages from the brain-oriented care. So one is the wider use of good basic resuscitation, early feeding and hygiene by empowering mothers for postnatal care, therapeutic normothermia and strict avoidance of hyperthermia, and better monitoring and supportive care of babies with encephalopathy, particularly with those with mild encephalopathy. I'd like to thank everyone who gave me an opportunity to speak about this. Thank you so much.
Thank you so much, Vaishak, for taking us through the topic. I would now like to